Hemorrhage for adequate visualization of the injuries. The right common iliac artery obscures the bifurcation of the vena cava and the right iliac vein. The iliac artery may require division to expose venous injuries in this area. Fig. 743. The artery must be repaired after the venous injury is treated, however, because of limb-threatening ischemia. Once overt hemorrhage is controlled, sources of enteric contamination are identified by serially running along the small and large bowel, looking at all surfaces. Associated hematomas should be unroofed to rule out adjacent bowel injury. The anterior and posterior aspects of the stomach should be inspected, which requires opening the lesser sac for complete visualization. Though no injuries should be evaluated with a wide Kocher maneuver. During exploration of the lesser sac, visualization and palpation of the pancreas is done to exclude injury. Palpating the anterior surface is not sufficient because they invest in. Table 7-9. Options for the treatment of vascular injuries. Observation, ligation, lateral suture repair, and palpation may mask a pancreatic injury. Mobilization, including evaluation of the posterior aspect, is critical. After injuries are identified, whether to use damage control techniques or perform primary repair of injuries is based on the patient's intraoperative physiologic status. See damage control surgery and treatment of specific injuries. In a patient with multisystem trauma, enteral access via gastrostomy or jejunostomy tube should be considered. If abdominal closure is indicated after the patient's injuries are addressed, the abdomen is irrigated with warm saline and the midline fascia is closed with a running heavy absorbable suture. The skin is closed selectively based on the amount of intra-abdominal contamination. Vascular repair techniques. Initial control of vascular injuries is accomplished digitally by applying enough direct pressure to stop the hemorrhage. Sharp dissection is used to define the injury and mobilize sufficient length for proximal and distal control. Fogarty thromboembolectomy should be done proximally and distally to optimize collateral blood flow. Heparinized saline 50 units/ml is then injected into the proximal and distal ends of the injured vessel to prevent small clot formation on the exposed intima and media. Ragged edges of the injury site should be debrided using sharp dissection. Intravascular shunts are used when there are multiple life-threatening injuries or the arterial injury is anticipated to require saphenous vein interposition reconstruction. Options for the treatment of vascular injuries are listed in Table 7-9. Arterial repair should always be done for the aorta, carotid, innominate, brachial, superior mesenteric, proper hepatic, renal, iliac, femoral, and popliteal arteries. Named arteries that usually tolerate ligation include the right or left hepatic artery and the celiac artery. In the lower extremities, at least one artery with distal runoff should be salvaged. Arterial injuries that may be treated non-operatively include small pseudoaneurysms, intimal dissections, small intimal flaps, and small arterial veins. Figure 743. The right common iliac artery can be divided to expose the bifurcation of the inferior vena cava and the right common iliac vein. 214. Part I. Basic considerations. Weeks after injury to confirm healing. Venous weeks after fistulas in the extremities. Follow-up imaging is performed 1 to 2 weeks after injury to confirm healing. Venous repair should be performed for injuries of the superior vena cava, the inferior vena cava proximal to the renal veins, and the portal vein, although the portal vein may be ligated in extreme cases. SMV should be repaired optimally, but 80% of patients will survive following ligation. Similarly, the left renal vein can usually be ligated adjacent to the IVC due to collateral decompression. The type of operative repair for vascular injury is based on the extent and location of injury. Lateral suture repair is preferred for arterial injuries with minimal loss of tissue. Endo and primary anastomosis is performed if the vessel can be repaired without tension. Arterial defects of 1 to 2 cm often can be bridged by mobilizing the severed ends of the vessel after ligating small branches. The aorta, subclavian artery, brachial artery, and popliteal artery, however, are difficult to mobilize for additional length. To avoid postoperative stenosis, particularly in smaller arteries, beveling or spatulation should be used so that the completed anastomosis is slightly larger in diameter than the native artery. Fig. 744. The authors emphasize the parachute technique to ensure precision placement of the posterior suture line. Fig. 745. If this technique is used, traction must be maintained on both ends of the suture, or leakage from the posterior aspect of the suture line may occur. Interposition grafts are used when end-to-end anastomosis cannot be accomplished without tension despite mobilization. For vessels 6 mm in diameter, for example, internal carotid, brachial, superficial femoral, and popliteal arteries, autogenous greater saphenous vein GSV from the contralateral groin should be used because polytetrafluoroethylene PTFE grafts of 6 mm have a prohibitive rate of thrombosis. When GSV is not available, autologous options include the cephalic and basilic veins. Larger arteries, for example, subclavian, innominate, aorta, common iliac are bridged by PTFE grafts. PTFE is preferred over Dacron because of the reported decreased risk of infection. 75. Aortic or iliac arterial injuries may be complicated by enteric contamination from colon or small bowel injuries. There is a natural. Figure 744. Small arteries repaired with an end-to-end anastomosis are reluctant to place artificial grafts in such circumstances, but graft infections are rare, and the time required to perform an axillofemoral bypass is excessive. Therefore, after the control of hemorrhage, bowel contamination is contained and the abdomen irrigated before placing PTFE grafts. 76. After placement of the graft, it is covered with peritoneum or omentum before definitive treatment of the enteric injuries. Transposition procedures can be used when an artery has a bifurcation and one vessel can be ligated safely. Injuries of the proximal internal carotid can be treated by mobilizing the adjacent external carotid, dividing it distal to the internal injury, and performing an end-to-end anastomosis between it and the distal internal carotid. Fig. 746. The proximal stump of the internal carotid is oversewn, with care taken to avoid a blind pocket where a clot may form. Injuries of the common and external iliac arteries can be handled in a similar fashion. Fig. 747, while maintaining flow in at least one internal iliac artery. Venous injuries should be repaired when technically feasible. Small injuries without loss of tissue can be treated with lateral suture repair. More complex repairs with interposition grafts may thrombose, but this typically occurs gradually over 1 to 2 weeks. During this time, adequate collateral circulation develops, which is sufficient to avoid acute venous hypertension. Therefore, it is reasonable to use ring PTFE for venous interposition grafting and accept a gradual, but eventual, thrombosis while allowing time for collateral circulation to develop. Such an approach is reasonable for venous injuries of the superior vena cava, suprarenal vena cava, SMV, and popliteal vein because ligation of these is associated with significant morbidity. In the remainder of venous injuries, the vein may be ligated. In such patients, chronic venous hypertensive complications in the lower extremities often can be avoided by a temporary use of elastic bandages, ACE wraps applied from the toes to the hips at the end of the procedure, and B. Judicious elevation of the lower extremities. These measures should be maintained for. Figure 746. Carotid transposition is an effective approach for treating injuries of the proximal internal carotid artery. 1 week, if the patient has no peripheral edema with ambulation. 215. These maneuvers are no longer required. Damage control surgery. The recognition of the bloody vicious cycle and the introduction of damage control surgery DCS have improved the survival of critically injured patients. Conceptually, the bloody vicious cycle, first described in 1981, is the lethal combination of coagulopathy, hypothermia, and metabolic acidosis. Fig. 748. Hypothermia from evaporative and conductive heat loss and diminished heat production occurs despite the use of warming blankets and blood warmers. The metabolic acidosis of shock is exacerbated by aortic clamping, administration of vasopressors, massive RBC transfusions, and impaired myocardial performance. The ACOT, described previously, is compounded by hemodilution, hypothermia, and acidosis. Once the cycle starts, each component magnifies the other, which leads to a downward spiral and ultimately a fatal arrhythmia. The purpose of DCS is to limit operative time so that the patient can be returned to the sickle for physiologic restoration and the cycle thereby broken. Indications to limit the initial operation and institute. DCS techniques include a combination of refractory hypothermia temperature 35 degrees C, profound acidosis arterial pH 7.2, base deficit 15 mol/L, and refractory coagulopathy. The decision to abbreviate a trauma laparotomy is made intraoperatively as the patient's clinical course becomes clear and laboratory values become available. The goal of DCS is to control surgical bleeding and limit gill spillage. The operative techniques used are temporary measures, with definitive repair of injuries delayed until the patient is physiologically replete. Controlling surgical bleeding while preventing ischemia is of utmost importance during DCS. Aortic injuries must be repaired using an interposition PTFE. Chapter Trauma. ID Figure 747. Transposition procedures can be used for iliac artery injuries to eliminate the dilemma of placing an interposition polytetrafluoroethylene graft in the presence of enteric contamination. A. Right common iliac artery transposed to left common iliac artery. B. Left internal iliac artery transposed to the distal right common iliac artery. C. Right internal iliac artery transposed to the right external iliac artery. 216. Severe trauma. Part. Immuno. Activation blood loss. Basic considerations. Activation/consumption of complement system and is indicated. Similarly, perfusion of the iliac system and infrainguinal vessels can be restored with a vascular shunt, with interposition graft placement delayed. Arterial reconstruction following shunt placement should be done optimally within 6 hours. 78. Venous injuries are preferentially treated with ligation and damage control situations, except for the suprarenal inferior vena cava and popliteal vein. For extensive solid organ injuries to the spleen or one kidney, excision is indicated rather than an attempt at operative repair. For hepatic injuries, perihepatic packing of the liver will usually tamponade bleeding. See Fig. 737. Translobar gunshot wounds of the liver are best controlled with balloon catheter tamponade, whereas deep lacerations can be controlled with Foley catheter inflation deep within the injury tract. Fig. 749. For thoracic injuries requiring DCS, several options exist. For bleeding peripheral pulmonary injuries, wedge resection using a stapler is performed. In penetrating injuries, pulmonary tractotomy is used to divide the parenchyma. Fig. 750. Individual vessels and bronchi are then ligated using a 3-0 polydioxanine suture PDS, and the tract is left open. Patients who sustain more proximal injuries may require formal pulmonary resection, but pneumonectomy is poorly tolerated. Recent experimental work suggests inhaled nitric oxide will reduce right heart failure following pneumonectomy. 79. Cardiac injuries may be temporarily controlled using a running 3-0 non-absorbable polypropylene suture or skin staples. Pledgeted repair should be performed for the relatively thin right ventricle. The second key component of DCS is limiting enteric content spillage. Small GI injuries, stomach, duodenum, small intestine, and colon may be controlled using a rapid whip stitch of 3-0 PDS. Complete transection of the bowel or segmental damage is controlled using a GIA stapler, often with resection of the injured segment. Alternatively, open ends of the bowel may be ligated using umbilical tapes to limit spillage. Pancreatic injuries, regardless of location, are packed and the evaluation of ductal integrity postponed. Urologic injuries may require catheter diversion. Before the patient is returned to the sickle, the abdomen must be closed temporarily. Temporary closure of the abdomen is accomplished using an antimicrobial surgical incised drape. IABN, 3M Healthcare, St. Paul, Fig. 751. In this technique, the bowel is covered with a fenestrated subfacial sterile drape 45 times 60 cm steri drape 3M healthcare, and 2 Jackson Pratt drains are placed along the facial edges. This is 217 Trauma. Chapter 7, Figure 749. A. An intrahepatic balloon used to tamponade hemorrhage from transhepatic penetrating injuries is made by placing a red rubber catheter inside a 1-inch Penrose drain, with both ends of the Penrose drain ligated. B. Once placed inside the injury tract, the balloon is inflated with saline until hemorrhage stops. C. A Foley catheter with a 30 ml balloon can be used to hold hemorrhage from deep lacerations to the liver. And covered using an iodine drape, which allows closed suction to control reperfusion-related acidic fluid egress while providing adequate space for bowel expansion to prevent abdominal compartment syndrome. During the initial DCS stage, the subfacial sterile drape is not covered by a blue towel so that the status of the bowel and hemorrhage control can be assessed. Use of direct peritoneal resuscitation following DCS should be considered. 18 FR round blade drains may be placed intraoperatively for the installation of the dialysate solution. 80. Return to the OR within 24 hours is planned once the patient clinically improves, as evidenced by normothermia, normalization of coagulation test results, and correction of acidosis. Treatment of specific injuries, head injuries, intracranial injuries. CT scanning, performed on all patients with a significant closed head injury GCS score 14, identifies and quantitates intracranial lesions as well as intracranial hypertension. Patients with intracranial hemorrhage, including epidural hematoma, subdural hematoma, subarachnoid hemorrhage, intracerebral hematoma or contusion, and diffuse axonal injury, are admitted to the sickle. In patients with abnormal Figure 750. Pulmonary tracheotomy divides the pulmonary parenchyma using a gastrointestinal anastomosis GIA stapler. The open tract permits direct access to injured vessels or bronchi for individual ligation. Findings on CT scans and GCS scores of less or equal to 8. Intracranial pressure ICP should be monitored using fiber optic intraparenchymal devices or intraventricular catheters. 3,381. Although an ICP of 10 mmHg is the upper limit of normal, therapy is targeted to maintain an ICP of 20 mmHg. 33. The newest neurosurgery guidelines additionally recommend maintaining the cerebral perfusion pressure CPP at 60 mmHg. Indications for operative intervention to remove space-occupying hematomas are based on the clot volume, amount of midline shift, location of the clot, GCS score, and height. 29. Shift of 5 mm typically is considered an indication for evacuation, but this is not an absolute rule. Smaller hematomas that are in treacherous locations, such as the posterior fossa, may require drainage due to brainstem compression or impending herniation. Removal of small hematomas may also improve ICP and cerebral perfusion in patients with elevated ICP that is refractory to medical therapy. Patients with diffuse cerebral edema resulting in excessive ICP may require a decompressive craniotomy, although a recent OS multicenter trial questioned the benefits. 8,283. Patients with open or depressed skull fractures, with or without sinus involvement, may require operative intervention. Penetrating injuries to the head may require operative intervention for hemorrhage control, evacuation of blood, skull fracture fixation, or debridement. General surgeons in communities without emergency neurosurgical coverage should have a working knowledge of burr hole placement in the event that emergent evacuation is required for life-threatening epidural hematoma. Fig. 752, 84. The typical clinical course of an epidural hematoma is an initial loss of consciousness, a lucid interval, and recurrent loss of consciousness with an ipsilateral fixed and dilated pupil. While decompression of subdural hematomas may be delayed, epidural hematomas require evacuation within 70 minutes. 83. The final stages of this sequence are caused by blood accumulation that forces the temporal lobe medially, with resultant compression of the third cranial nerve and eventually the brainstem. The burr hole is made on the side of the dilated pupil to decompress the intracranial space. After stabilization, the patient is transferred to a facility with neurosurgical capability for formal craniotomy. In addition to operative intervention, post-injury care directed at limiting secondary injury to the brain is critical. The goal of resuscitation and management in patients with head injuries is to avoid hypotension SPP of 100 mmHg and hypoxia partial pressure of arterial oxygen of 60 or arterial oxygen saturation of 90%. 33. Attention, therefore, is focused on maintaining cerebral perfusion rather than merely lowering. 218. Part I. Basic considerations. A B. CD Figure 751. Temporary closure of the abdomen entails covering the bowel with a fenestrated subfacial 45 times 60 cm sterile draper, placing Jackson Pratt drains along the facial edge B, and then occluding with an iodine drape C. D. Resuscitation efforts aim for euvolemic state and a SPP of 100 mmHg. Cerebral perfusion pressure CPP is equal to the mean arterial pressure minus the ICP, with a target range of 60 mmHg. 33. CPP can be increased by either lowering ICP or raising mean arterial pressure. Sedation, osmotic diuresis, paralysis, ventricular drainage, and barbiturate coma are used in sequence, with coma induction being the last resort. The role of decompressive craniotomy for refractory ICH remains controversial. 82. The partial pressure of carbon dioxide PC aqua should be maintained in a normal range 35, 40 mmHg, but for temporary management of acute intracranial hypertension, inducing cerebral vasoconstriction by hyperventilation to a PC aqua. Figure 752. A burr hole is made for decompression of an epidural hematoma as a life-saving maneuver. One or more branches of the external carotid artery usually must be ligated to gain access to the skull. No attempt should be made to control intracranial hemorrhage through the burr hole. Rather, the patient's head should be wrapped with a bulky absorbent dressing and the patient transferred to a neurosurgeon for definitive care. mmHg is occasionally warranted. Moderate hypothermia 32 degrees, 33 degrees C 89, 6 degrees, 91, 4 degrees F has been shown experimentally to improve neurologic outcomes, but clinical studies have not validated this concept. 338,586 patients with intracranial hemorrhage should be monitored for post-injury seizures, and prophylactic anticonvulsant therapy is indicated for 7 days after injury. 33. Maxillofacial injuries. Maxillofacial injuries are common with multisystem trauma and require coordinated management by the trauma surgeon and the specialists in otolaryngology, plastic surgery, ophthalmology, and oral and maxillofacial surgery. Delay in addressing these systems that control vision, hearing, smelling, breathing, eating, and phonation may produce dysfunction and disfigurement with serious psychological impact. The maxillofacial complex is divided into 3 regions: the upper face containing the frontal sinus and brain, the midface containing the orbits, nose, and zygomatic maxillary complex, and the lower face containing the mandible. High-impact kinetic energy is required to fracture the frontal sinus, orbital rims, and mandible, whereas low-impact forces will injure the nasal bones and zygoma. The most common scenario, which at times may be life-threatening, is bleeding from facial fractures. 87. Temporizing measures include nasal packing, Foley catheter tamponade of posterior nasal bleeding, and oropharyngeal packing. Prompt embolization will halt exsanguinating hemorrhage. Fractures of tooth-bearing bone are considered open fractures and require antibiotic therapy and semi-urgent repair to preserve them. Airway as well as the functional integrity of the occlusion by 219 trauma and the aesthetics of the face. Orbital fractures may compromise vision, produce muscle injury causing diplopia, or change orbital volume to produce a sunken appearance to the orbit. Nose and nasopharyngeal fractures should be assessed carefully to identify damage to the lacrimal drainage system or to the cribriform plate producing cerebrospinal fluid rhinorrhea. After initial stabilization, a systematic physical examination of the head and neck should be performed that also includes cranial 7 nerve examination and 3-dimensional CT scanning of the maxillofacial complex Fig. 753. Cervical injuries, spine. Treatment of injuries to the cervical spine is based on the level of injury, the stability of the spine, the presence of subluxation, the extent of angulation, the level of neurologic deficit, and the overall condition of the patient. In general, physician supervised axial traction, via cervical tines or the more commonly used halo vest, is used to reduce subluxations and stabilize the injury. Mobilization of injuries also is achieved with spinal orthosis braces, particularly in those with associated thoracolumbar injuries. Surgical fusion typically is performed in patients with neurologic deficit, those with angulation of 11 degrees or translation of 3.5 mm, and those who remain unstable after halo placement. Indications for immediate operative intervention are deterioration in neurologic function and fractures or dislocations with incomplete deficit. Historically, methylprednisolone was administered to patients with acute spinal cord injury after blunt injury, with clinical data suggesting a small benefit to initiating a 24-hour infusion if started within 3 hours and a 48-hour infusion if started within 3 to 8 hours. 88. Current guidelines, however, no longer recommend steroids for acute injuries. 89. The role and timing of operative surgical decompression after acute spinal cord injury is debated. Chapter, Figure 753. 3-dimensional computed tomography scan illustrating the Fort Roman 2 maxillary L and alveolar fractures, and fracture of the mandible M at the midline and at the weaker condyle C. Used with permission from Vincent D. Husterman, MD, DDS. 220, Part I. Basic considerations. The concept of damage control has been suggested. However, evidence supports urgent decompression of bilateral lock facets in patients with incomplete tetraplegia or with neurologic deterioration. Performing surgery within 24 hours may decrease length of stay and complications. 90. Complete injuries of the spinal cord remain essentially untreatable. Yet, approximately 3% of patients who present with flaccid quadriplegia have concussive injuries, and these patients represent the very few who seem to have miraculous recoveries. Vascular. Cervical vascular injuries due to either blunt or penetrating trauma can result in devastating neurologic sequelae or exsanguination. Penetrating injuries to the carotid artery and internal jugular vein usually are obvious on operative neck exploration. The principles of vascular repair techniques discussed previously apply to carotid injuries, and options for repair include end-to-end primary repair, often possible with mobilization of the common carotid, graft interposition, and transposition procedures. All carotid injuries should be repaired except in patients who present in coma with a delay in transport. Prompt revascularization of the internal carotid artery using a temporary prudent or shunt should be considered in patients arriving in profound shock. Otherwise, carotid shunting should be done selectively as an elective carotid endarterectomy, but the patient should be systemically anticoagulated. Currently, we administer heparin with an ACT target of 250 seconds. Tangential wounds of the internal jugular vein should be repaired by lateral venorrhaphy, but extensive wounds are efficiently addressed by ligation. However, it is not advisable to ligate both jugular veins due to potential intracranial hypertension. Vertebral artery injuries due to penetrating trauma are difficult to control operatively because of the artery's protected location within the foramen and transversarium. Although exposure from an anterior approach can be accomplished by removing the anterior elements of the bony canal and the tough fascia covering the artery between the elements, typically the most efficacious control of such injuries is embolization. Barbardi catheter balloon occlusion, however, is useful for controlling acute bleeding if encountered during neck exploration. Blunt injury to the carotid or vertebral arteries may cause dissection, thrombosis, or pseudoaneurysm, typically in the surgically inaccessible distal internal carotid Fig. 754, 91. Early recognition and management of these injuries is paramount because patients treated with antithrombotics have a stroke rate of 1% compared with stroke rates of 20% in untreated patients, 92. 9. Because treatment must be instituted during the latent period between injury and onset of neurologic sequelae, diagnostic imaging is performed based on identified risk factors. Fig. 755, 92. After identification of an injury, antithrombotics are administered if the patient does not have contraindications: intracranial hemorrhage, falling hemoglobin level with solid organ injury, or complex pelvic fractures. Heparin, started without a loading dose at 15 units/kilogram per hour, is titrated to achieve a PTT between 40 and 50 seconds, or antiplatelet agents are initiated: aspirin 325 mg/d or clopidogrel 75 mg/d. The types of Figure 754. The Denver Grading Scale for Blunt Cerebrovascular Injuries. Grade I, irregularity of the vessel wall, dissection/intramural hematoma with 25% luminal stenosis. Grade Roman II, visualized intraluminal thrombus or raised intimal flap, or dissection/intramural hematoma with 25% or more luminal narrowing. Grade Roman III, pseudoaneurysm. Grade Roman IV, vessel occlusion. CAI equals carotid artery injury. VAI equals vertebral artery injury. Denver Health Medical Center BCVI screening guideline. Signs/symptoms of BCVI: potential arterial hemorrhage from neck/nose/mouth, cervical brood, and PT 50 years old, expanding cervical hematoma, focal neurologic defect, T. Hemiparesis, vertebrobasilar symptoms, Horner syndrome, neurologic deficit, inconsistent with head CT. Antithrombotic treatment appear equivalent in published studies to date, and the duration of treatment is empirically recommended to be 6 months. 9,394. The role of carotid stenting for grade Roman II or Roman III internal carotid artery injuries remain controversial. Current literature suggests stenting be reserved for symptomatic patients or markedly enlarging pseudoaneurysms. 95. Thrombosis of the internal jugular veins caused by blunt trauma can occur unilaterally or bilaterally and is often discovered incidentally because most patients are asymptomatic. Bilateral thrombosis can aggravate cerebral edema in patients with serious head injuries. Stent placement should be considered in such patients if ICP remains elevated. 222. Part I. Basic considerations. Aerodigestive. Fractures of the larynx and trachea may manifest as cervical emphysema. Fractures documented by CT scan are usually repaired. Common injuries include thyroid cartilage fractures, rupture of the thyroepiglottic ligament, disruption of the arytenoids or vocal cord tears, and cricoid fractures. After debridement of devitalized tissue, tracheal injuries are repaired and using a single layer of interrupted absorbable sutures. Associated injuries of the esophagus are common in penetrating injuries due to its close proximity. After debridement and repair, vascularized tissue is interposed between the repaired esophagus and trachea, and a closed suction drain is placed. The sternocleidomastoid muscle or strap muscles are useful for interposition and help prevent postoperative fistulas. Chest injuries. The most common injuries from both blunt and penetrating thoracic trauma are hemothorax and pneumothorax. More than 85% of patients can be definitively treated with a chest tube. The indications for thoracotomy include significant initial or ongoing hemorrhage from the tube thoracostomy and specific imaging. Identified diagnosis table 710. One caveat concerns the patient who presents after a delay. Even when the initial chest tube output is 1.5 L, if the output ceases and the lung is re-expanded, the patient may be managed non-operatively if hemodynamically stable. Grade vessels. Over 90% of thoracic grade vessel injuries are due to penetrating trauma, although blunt injury to the innominate, subclavian, or descending aorta may cause a pseudoaneurysm or frank rupture. 469,697 simple lacerations of the ascending or transverse aortic arch can be repaired with lateral aortography. Repair of posterior aortic injuries, complex ascending or transverse injuries, or those requiring interposition grafting of the arch, require full cardiopulmonary bypass. Innominate artery injuries are repaired using the bypass exclusion technique, which avoids the need for cardiopulmonary bypass. Bypass grafting from the proximal aorta to the distal innominate with a prosthetic tube graft is performed before the post-injury hematoma is entered. The PTFE graft is anastomosed and tosside from the proximal undamaged aorta and anastomosed endo into the innominate artery. Fig. 756. The origin of the table 710. Indications for operative treatment of thoracic injuries. Initial tube thoracostomy, drainage of 1,000 ml, penetrating injury or 1,500 ml, blunt injury, ongoing tube thoracostomy, drainage of 200 ml/H for 3 consecutive hours in non-coagulopathic patients. Cake hemothorax despite placement of 2 chest tubes. Great vessel injury. Endovascular techniques may be used in selected patients. Pericardial tamponade. Cardiac herniation, massive air leak from the chest tube with inadequate ventilation. Tracheal or main stem bronchial injury diagnosed by endoscopy or imaging. Open pneumothorax, esophageal perforation, air embolism. Innominate is then oversewn at its base to exclude the pseudoaneurysm or other injury. Subclavian artery injuries can be repaired using lateral arteriography or PTFE graft interposition. Due to its multiple branches and tethering of the artery, tone primary anastomosis is not indicated if there is a significant segmental loss. Descending BAI may require urgent intervention. However, operative intervention for intracranial or intra-abdominal hemorrhage or unstable pelvic fractures takes precedence. To prevent aortic rupture, pharmacologic therapy with a selective B antagonist, esmolol, should be instituted in the trauma bay, with a target SPP of 100 mmHg and heart rate of 100/minute. 4,198. Endovascular stenting is now the mainstay of treatment. 99,100. While endograft sizing has improved, The major question is long-term outcome in younger patients. Open repair of the descending aorta is accomplished using partial left heart bypass to prevent spinal cord and splanchnic ischemia and reduce left ventricular afterload. Fig. 757, 101 non-operative management for grade I. BC, figure 756. A. Angiography reveals a 1. cm pseudoaneurysm of the innominate artery origin. B. In the first stage of the bypass exclusion technique, a 12 mm polytetrafluoroethylene graft is anastomosed end aside from the proximal undamaged aorta, tunneled under the vein, and anastomosed end to the innominate artery. C. The origin of the innominate is then oversewn at its base to exclude the pseudoaneurysm. LA, figure 757. When repairing a tear of the descending thoracic aorta, perfusion of the spinal cord while the aorta is clamped is achieved by using partial left heart bypass. Venous cannula is inserted into the left superior pulmonary vein because it is less prone to tearing than the left atrium. LA. Intimal aortic injuries is accomplished with antiplatelet agents and blood pressure control. 102. Or, blunt and penetrating cardiac injuries have widely differing presentations and therefore disparate treatments. Survivable penetrating cardiac injuries consist of wounds that can be repaired operatively. Most are stab wounds. Before repair of the injury is attempted, hemorrhage should be controlled. Injuries to the atria can be clamped with a Satinsky vascular clamp, whereas digital pressure is used to occlude the majority of ventricular wounds. Foley catheter occlusion of larger stellate lesions is described, but even minimal traction may enlarge the original injury. Temporary control of hemorrhage, and at times definitive repair, may be accomplished with skin staples for left ventricular lacerations. The myocardial edges of the laceration must coat in diastole for stapling to be technically feasible. Definitive repair of cardiac injuries is performed with either 223 trauma running 3-0 polypropylene suture or interrupted, pledgeted 2-0 polypropylene suture fixating 58103. Use of pledges may be particularly important in the right ventricle to prevent sutures from pulling through the thinner myocardium. Injuries adjacent to coronary arteries should be repaired using horizontal mattress sutures because use of running sutures results in coronary occlusion and distal infarction. Gunshot wounds may result in stellate lesions or contused, extremely fibrillate myocardium adjacent to 7 to wound. When the edges of such complex wounds cannot be fully approximated and hence the repair is not hemostatic, the authors have used surgical adhesive bioglue to achieve hemostasis. 104. Occasionally, interior structures of the heart may be damaged. Intraoperative auscultation or postoperative hemodynamic assessment usually identifies such injuries. 105. Echo can diagnose the injury and quantitate its effect on cardiac output. Immediate repair of valvular damage or septal defects rarely is necessary and would require cardiopulmonary bypass, but structural intracardiac lesions may progress, and thus patients must have a follow-up echo. Patients with blunt cardiac injury typically present with persistent tachycardia or conduction disturbances, but occasionally present with tamponade due to atrial or right ventricular rupture. There are no pathognomonic ECG findings, and cardiac enzyme levels do not correlate with the risk of cardiac complications. 25. Therefore, patients for whom there is high clinical suspicion of cardiac contusion and who are hemodynamically stable should be monitored for dysrhythmias for 24 hours by telemetry. Patients with hemodynamic instability should undergo echo to evaluate for wall motion abnormalities, particularly hypokinesis of the right ventricle, pericardial fluid, valvular dysfunction, chordae rupture, or diminished ejection fraction. If such findings are noted or if vasoactive agents are required, cardiac function can be continuously monitored using a pulmonary artery catheter and serial sickle transthoracic or transesophageal echo. Chapter, Trachea, Bronchi, and Lung Parenchyma. Less than 1% of all injured patients sustain intrathoracic tracheobronchial. Figure 758. A variety of techniques may be necessary to repair cardiac wounds. Generally, pledged support is used for the relatively thin-walled right ventricle. 224. Part I. Basic considerations. Injuries, and only a small number require operative intervention. Although penetrating injuries may occur throughout the tracheobronchial system, blunt injuries most commonly occur within 2.5 cm of the carina. For patients with a massive air leak requiring emergent exploration, initial control of the injury to provide effective ventilation is obtained by passing an endotracheal tube either beyond the injury or into the contralateral mainstem bronchus. Principles of repair are similar to those for repair of cervical tracheal injuries. The vitalized tissue is debrided, and primary end-to-end anastomosis with 3-0 PDS suture is performed. Dissection should be limited to the area of injury to prevent disruption of surrounding bronchial vasculature and ensuing ischemia and stricture. Suture lines should be encircled with vascularized tissue, either pericardium, intercostal muscle, or pleura. Expected management is employed for bronchial injuries that are less than 1/3 the circumference of the airway and have no evidence of a persistent major air leak. 1112. In patients with peripheral bronchial injuries, indicated by persistent air leaks from the chest tube and documented by endoscopy, bronchoscopically directed fibrin glue sealing may be useful. The majority of pulmonary parenchymal injuries are suspected based upon identification of a pneumothorax. The vast majority can be managed with a tube thoracostomy. Identified parenchymal injuries encountered during thoracic exploration for massive hemothorax are managed without resection as much as possible. Bronchovenous fistula is a constant threat and should be minimized by prompt control of a major air leak. Peripheral lacerations with persistent bleeding can be managed with staple wedge resection. For central injuries, the current treatment is pulmonary tracheotomy, which permits selective ligation of individual bronchioles and bleeders, prevents the development of an intraparenchymal hematoma or air embolism, and reduces the need for formal lobar resection. See Fig. 750. 106,107. Stapling device, preferably the longest stapler available, for example, GIA 100, is inserted directly into the injury tract and positioned along the thinnest section of overlying parenchyma. The injury tract is thus filleted open, which allows direct access to the bleeding vessels and leaking bronchi. The majority of injuries are definitively managed with selective ligation, and the defect is left open. Occasionally, tractotomy reveals a more proximal vascular or bronchial injury that must be treated with formal lobectomy. Injuries severe enough to mandate pneumonectomy usually are fatal because of right heart decompensation. 108. One parenchymal injury that may be discovered during thoracic imaging is a post-traumatic pulmonary pseudocyst, colloquially termed a pneumatossal. 109. Traumatic pneumatossals typically follow a benign clinical course and are treated with aggressive pain management, pulmonary toilet, and serial chest radiography to monitor for resolution of the lesion. If the patient has persistent fever,